This is the appointed time and we have a quorum, so I call this meeting to order. Item 1 on the agenda. Further discussion on legislative proposals to enhance the regulation of pharmaceutical products. A lot of papers from the administration and the responses, all of them have been circulated to members by the Secretariat. Let's invite the administration in. So, Undersecretary, are you seated? All right. Is there any new paper from the administration? No. So, anything to supplement? Yes. Yes, please proceed. Thank you, Chairman. Well, first of all, we thank members and deputations for supporting our proposal to enhance the regulation of pharmaceutical products in Hong Kong. And they have also given some valuable views to our legislative proposal in the previous meetings. And we have carefully considered and followed up on these views, and without affecting the effect of the legal framework, we have made suitable adjustments. And some members of the sector on the at the special meeting on the 10th of December 2013 expressed concerns, and we have duly followed up on these concerns, and we have decided to take on board the sector's suggestions so that registered pharmacists are required only to be present at 2/3 of the business hours of the authorized seller of poisons, ASP. We will not extend this requirement so that pharmacists have to be present at all hours. And last year, on the 16th of December, we issued another paper to the panel explaining the change. And for members to better understand, the study conducted on the in March 2009 and the consultation on the in January 2014, we also issued a letter to the panel setting out in detail our work, and through the papers submitted to this panel, members should understand that through various platforms we have over the years have had rounds of discussion and consultation, and the views and concerns expressed by various stakeholders have been incorporated in our proposal. We have suitably amended our proposal, and some groups have expressed particular issues, and we would like to respond to these issues. First, on vitamin supplements, hair dyes, and nutritional dietary supplements, and also issues relating to the receptacles for containing peptide poison. The Department of Health met with some groups and will be meeting with other groups in due course to clarify the intention and objectives of the legislation, the modus operandi, and also to explain and allay their concerns. We believe the relevant meetings should be able to clarified and allay the sector's concerns. And our legislative proposal will not affect the regulation of hair dyes under the Pharmacy and Poisons Ordinance, and also for the hair dye containing certain chemicals, the relevant manufacturers are required to possess licenses and subject to random inspections. Our proposal will not affect the current supervision arrangement, and as hair dye does not contain any pharmaceutical product per se, it will not be subject to the requirement of keeping records. As for nutritional supplement or minerals and diet supplements, again, as they do not contain any pharmaceutical ingredients listed in the schedule, this will not be subject to the PPO, and the present arrangement will not be changed. The next one is vitamin supplements. All along, it has been regarded as a pharmaceutical product. It must be registered before sale in the market in Hong Kong. So under the current legislation, the wholesalers of these non-poison vitamin supplements will be subject to the same requirements as the wholesalers of other non-poison pharmaceutical products. They will be subject to inspection checks, and they will be required to keep records. And wholesaler and retailers will not be included. And also about the receptacles for containing Part 1 poison, the administration's view is that only registered pharmacists should possess the key or have access, and other staff should not provide such pharmaceutical products to consumers without the presence of a registered pharmacist in the dispensary. And we wish to extend the requirement of locking the pharmaceutical products in receptacles to include Part 1 poison, because they could be more harmful, and they should reasonably be under the control of registered pharmacists. As for ordering drugs in written form, we stated verbally and again in our paper that in relation to wholesalers, retailers, and manufacturers, we wish to include this requirement in the by administrative means as one of the good practices for them to follow. And this will not be part of the legislation, and this is and in preparing the good manufacturing practice, the Pharmacy and Poisons Board will continue to fully consult the sector. We hope that by implementing the above measures, we can allay the concerns raised by the sector and members in previous meetings. On another point, there are members of the sector who would like the administration to amend this legislation as soon as possible to enhance the efficiency of the pharmaceutical trade and to enhance safety. For example, in relation to the validity period of clinical certificate for pharmaceutical products and lab tests to provide greater better safety. So we urge members to support us to submit this proposal in the first half of this year, and we'll be happy to explain in greater detail any issues raised by members and or the sector on implementation details, the provisions, and also to have a very constructive exchange. Do you have a speaking note for your for what you've said just now? Because you mentioned nothing about vitamins, hair dyes, and also communication in the sector. Nothing in your paper.
In our previous letter, we did mention that. Mr. Vincent Fang, 5 minutes, questions and answers. There should be enough time. 5 minutes, questions and answers. I thank you, the Undersecretary, for her reply. I thank you for accepting a lot of the views of the trade concerning hair tinting materials. I thank the Bureau for excluding it from poison, from the category of poison, and that is supported by the trade. But as for vitamins, I know that some vitamins are for medical treatment and some are similar to medicine. Concerning health supplements, there is a certain category called health supplements in other countries, or health food. I think that will become more and more popular. With progress of society, people may prefer to take so-called supplements, health supplements, to strengthen their health. I don't know whether the administration will set up another set category, and there will be a separate regulatory regime for health supplements. Concerning the key, I think you can still recall that many pharmacists are afraid of taking the responsibility. If the key is given to the pharmacist, then the pharmacist is held responsible for everything. If the boss is not the pharmacist, then it's really unreasonable in the mind of the boss that he doesn't have the key. But if there is a second key, then the pharmacist will not be willing to take up the responsibility. So if you want to implement this provision, will the administration tell the boss that the key, there will only be one key, and that will be held by the pharmacist? And if you have a key, if the boss has a key, then the pharmacist will add a lock and a separate key to make sure that he is the one who only have access. As for writing orders, we agreed in principle to that, but what do you mean by writing? Can you broaden the scope, say by email, by fax, or by what, so as to facilitate the ordering of pharmaceutical products? The Undersecretary, I thank Mr. Fang for his questions, and I also thank him for his recognition given to the work we have done since the last meeting. With regard to vitamins, at present they are pharmaceutical products. Concerning health supplements, we've looked into that. In the international community, there is no standardized approach in defining what is meant by a health supplement. At present, there is no law to regulate that. We look at the ingredients of the health supplements, and the health supplements are regulated by different laws. Say, for example, the Pharmaceutical and the Poison and Pharmaceutical Ordinance, or the Chinese Medicine Ordinance. If health supplements do not contain medicine, then they are regulated by the Public Health and Municipal Services Ordinance. And since we have also regulation on advertising, we believe we have the current legislation suitable to regulate health supplements. As for the key, of the receptacle. Now, the pharmacist is responsible for holding the key. This is an existing provision in the law. It's not a new proposal. The key is to be held by the registered pharmacist. We expand the scope of Part 1 poison to cover to put it under this requirement. Otherwise, there will be a severe loophole. If the boss is not the pharmacist, then he cannot hold the key. That's under the current law. We don't want to cause any confusion. We want to maintain effective supervision. Therefore, the key should be held only by the pharmacist. As for whether we would communicate with the dispensary owners, we will certainly do so, and the health department will deal with that. As for the written order, there is flexibility. Emails, faxes are regarded as written orders. Thank you. Next, Mr. Pun Siu-ping. Thank you, Chairman. Just now, the administration said that it had listened to the views of the deputations. The 2/3 business hour requirement, I think the proposal has been withdrawn. I don't know what's the response of the deputations. I just want to follow up on the point raised by Mr. Fang, which is about the pharmacists. I met 2 pharmacist groups. They agreed that there is an existing provision. If you change the law, then the power of the pharmacist is reduced, and yet the responsibility is broadened. The boss has the key as well. You don't need to add anything to the existing law, and can you still solve the problem? The Undersecretary, first, concerning the 2/3 business hours. In our first proposal, we proposed 100% of the time. 100% of the time was the original proposal, and we know that there may not be adequate number of pharmacists to achieve that goal. Although we had the proposal, we said that the time for implementation would be only announced later. Now, we've heard the view of members and also the pharmacists, and we maintain the current situation, and that is 2/3 of business hours. And we do not impose the 100% requirement. As for the key, the existing law requires the pharmacist to be the only person who holds the key for the receptacles of the poisons. Our proposal is does not add anything to that. It's just that he has to look after more medicines, including Part 1 poison. Any other views? Well, then it's my turn now. 2 members have come in late. First, on the key, I just want to clarify the bone of contention. The Undersecretary, you said that is in the existing law. Do you refer to 138A, Section 19? Am I correct? Cap 138A, Section 19. It says that the receptacle must be locked, and the key to the lock should be kept by the pharmacist, registered pharmacist. The pharmacist associations say that you add the word only, which is different from the present provision. So there are 2 different understandings. The government is the view that even the word only is not present in the existing provision, it carries the same meaning. So in the new regulation, you add the word only, or in the amendment regulation, you add the word only, so there is no change. The word only is not present. I think the greatest reaction is on the word only, the AD. Our proposal does not add the word only. What is your proposal in regard to this provision? Schedule 1 is changed to pipeline poison. Section 19(2)(a). There is no change, no amendment, not at all. In your paper, you have the word only. Yes, in the law there is no such word, and there will not be change. There will not be any change. Section 19(2). No person shall store any substance included in first schedule in any retail shop, blah, blah, blah. No person. Now, if a person breached that person is in breach of the law. Does the person refer to the owner or the pharmacist? Any person. Any person. If this person has not locked up the things under schedule, the first schedule, then that one will be held responsible. According to the wording, it seems the reference is only to the reference is to the owner of the dispensary. Can the owner of the dispensary be any person? Be the person. Now the pharmacist holds the key and he doesn't know whether this is the only key. If this is not the only key, who is to be held responsible? It says no person shall store any substance included in the first schedule in any retail shop, blah, 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 stored in a receptacle. How should I understand the word person? The person is found. Say if there is a case, a medicine should be locked up, but it is found that the medicine is not locked up, then evidence has to be found and to prove who has not locked this up. Now, if you get a lawyer to defend you, there are many conditions present before the offense is considered to have been committed. Say, the receptacle has the medicine. The second question is how many people have the key. There are many elements in that act, right? Some elements are controlled by the pharmacist and some elements are not. And the pharmacist does not know whether he has become the person that is mentioned in the law. Now that's about the breach. Maybe the Undersecretary can help, or rather the Deputy Secretary can help. In fact, there is no change in the law, as you concerning the two provisions which you mentioned. Now, some medicines have to be locked up, and if the medicines are locked up, then the key has to be held by the registered pharmacist only. Now, according to the law, if some people who doesn't lock up the medicine that should have been locked up, then the person is in breach of the law. The person can be the pharmacist, the person can be anybody, including the owner of the dispensary.
So sorry, let me follow up. Say someone might have committed all the elements concerned. Then one of the elements might be that he is in possession of the key and he is not the pharmacist, but the pharmacist may not have no idea. Then would the pharmacist be regarded as the person? Because in an offense, you need to have a number of elements. First, you need to have poisons locked up, and then somebody else is possessing the key other than the pharmacist. So please explain to us who the person refers to. Yes, I think under such circumstances, you need to look at the circumstantial evidence. And this legislation is, in fact, under review. If somebody steals the key, and there are a number of possibilities, we must look at the evidence. So, in short, I mean, to put it simply, if somebody else other than the pharmacist possesses the key, the pharmacist may not be committing an offense. Well, I think this is just hypothetical, but this is highly likely. Say somebody might have stolen the key without his knowledge and or made a copy or made a duplicate key. There are many possibilities, Mr. Chen Han-pen. I'd like to follow up on this question as well. Say, for example, somebody ordered such drugs so that the drugs are now delivered in the dispensary. Normally, the pharmacist should be informed so that the drugs will be locked up, and then he failed to notify the pharmacist, and the drugs are not locked. And in the end, can you say that the responsibility lies with the pharmacist or the person handling the goods and not passing the drugs to the pharmacist will be liable? All right, on this proposal, we see the administration is not trying to stifle the room for smaller dispensaries and pharmacies to survive. Haven't taken on board the sector's views, as you have followed up on these views and improved your proposal. On placement of drugs, the original proposal is that telephone orders would not be allowed, and you now permit placement via email and faxes, and we welcome this change. And there are some rather complicated and controversial issues. On the issue of keys, I don't know whether there's a problem with communication. There were repercussions. So the administration should clarify the position. And in the paper, there is also a point about dividing pharmacy and medicine as separate, or a prescription and medical consultation should be separated. I don't know whether you have a timetable when we're going to discuss this. Thank you, Mr. Chen. Well, on this issue of separating prescription from medical consultation, the issue is rather complex. At present, people consult private doctors, and we need to look at the prevailing practice and also whether we have sufficient pharmacists. We have a manpower review, our planning committee under our bureau, and apart from manpower, they also look at professional development. There are 6 disciplines, and pharmacist is one of them. And these issues have been raised, and some work are being done in this regard. So in terms of professional development, this issue will be explored further. However, apart from consulting the sector, we also need to engage the public extensively. At present, patients can ask doctors to give prescriptions for them to get medicine from a pharmacist on doctor's prescription, should it be necessary. Dr. Kwokaki, the administration's proposal has changed after the sector expressed their views at the previous meetings on the requirement of pharmacists being present at all times. Well, this is the government's intention now. You have changed it. I don't know whether this will be a temporary change or a permanent change. Originally, the administration's objective is to enhance the efficiency and accuracy of the pharmacist's work and safeguard public health. And this will be departing from this original intention. So I wonder if this is a permanent change or a temporary change. And on the issue of keys, I think in future the liability should be more clearly defined. We all understand that if you're the owner of a pharmacy, they bear no liability. They can just start up another dispensary or pharmacy and hire another registered pharmacist. We've seen such examples. Even in the same street, they can open another store. So for these owners, although I believe the majority of pharmacy owners are law compliant and they are in no way trying to circumvent the law, but the fact is we do have a big loophole. The responsible person or the owner of the pharmacy shifts the responsibility onto pharmacists, and this is a big loophole. And the owner of the pharmacy should also bear the same legal responsibility. If the registered pharmacist commits professional misconduct, he may be subject to the license being suspended. Why can't we have a similar registration system for pharmacy owners so that such owners can be prevented from carrying on the same line of business? I think you understand this better than I do. Some pharmacies sell poisons, some don't. Some sell health food, and some sell psychotropic substances and cough syrups, which can be abused. The Department of Health has done numerous inspections. Have there been many cases involving keys and receptacles? And how many cases have you found in your inspection? And what is the successful prosecution cases? And the Secretary, on the presence of registered pharmacists round the clock, the original proposal was that the pharmacists should be present at all times, and we felt that this would be a step towards better protecting public health and enhancing the overall monitoring. And there were views from members as well as sectors, and we also understood that we don't have sufficient pharmacists, and that's why we did not provide a timetable. We agreed that it should be kept flexible. And since things are now controversial, and we did not originally have a timetable anyway, we will set this aside for the time being. But the direction remains the same. We would like to enhance supervision and protect the public's health. This remains unchanged, so in future we will explore for example, how many pharmacists we need and what the development will be. And as I said, we have a steering committee on medical manpower planning, and one of the areas will be professional development, and they will also look into this issue. Say if this is feasible and this is the direction, do you have a timetable? We don't have a specific timetable. We need to have sufficient number of pharmacists in order to implement this proposal. And last time we heard even pharmacists didn't think we should implement this too quickly, and we would therefore actively follow up on it only in the future. And on the point of keys, maybe I'll defer to Assistant Director. On keys, as mentioned just now, say if an offense has been committed, not necessarily by a pharmacist. It depends on the circumstances of the case, and in the process of gathering evidence, if someone is found to have breached the law and that things should be locked up have not been locked up, we will prosecute that person. That person could be the employer, the pharmacist, the employee, pharmacist, or even owner of the pharmacy. And if the owner commits an offense, and if there is a joint prosecution by our department and the police, the owner may be subject to disciplinary action under the Pharmacy and Poisons Board. There will be a disciplinary hearing, and this may lead to a suspension of his license or the issuance of a warning. And if some dispensaries repeatedly are repeatedly penalized by us, such that it eventually closes down, and if the owner then starts another dispensary in the vicinity, there is a question on whether we will issue a license to the same owner, since that same owner has just been penalized by us for breach of the relevant Pharmacy and Poisons ordinance. And if he's applying for another license, we will be a very strict gatekeeper. All right. What about statistics or figures? Yes, we inspect dispensaries. What about prosecution cases? We can provide them later. Next, Dr. Fernando Zhang. Thank you, Chairman. Well, we see that the administration has retracted as far as this legislative proposal is concerned. The presence of a registered pharmacist at all times during the business hours of the premises provide safeguard the public's health. The sector has expressed reservations. Of course, they have reservations because this will increase their costs, but on the other hand, it will enhance protection of public health. And in the end, you gave in, and I wonder why you could do it so quickly. And on placing drug orders in written form, originally it would be part of the legislation. Now again you retracted. This will only be implemented by administrative means in the GMP or the Code of Practice. Now, if they are not complying with the COP, does it constitute an offense? If no one reports the case, and if somebody breaches the law and a patient doesn't know how to report such cases, then is there any really enforcement strength in the COP? And I know that some dispensaries issue cards, and if the patient goes to the dispensary to prescribe drugs with the prescription, a card will be issued by the dispensary so that next time no prescription will be required. Only the card will be necessary. So you only need to present the prescription once, and next time you can prescribe drugs. You can get drugs from them. And is it included in the COP? And the Secretary. To respond to your point on the 2/3 of the business hours, I mentioned 100% just now. We understood that it will be difficult to implement because we don't have enough manpower. So we have not provided a timetable. We keep an open mind.
In answering Dr. Kwok's question, I've already said that we don't put it in for the time being because we don't have a timetable, or since we don't have a timetable. Now, the general direction has not changed. We want to consider the matter in greater detail. We want to do more preparation before we move forward. But I can say that we have not changed the direction. We still are committed to protecting people's health. As for written order, the DS can speak on that. The DS. Concerning the requirement of a written order, it has all along been under the Code of Practice. We wanted to amend the law to authorize us to draw up the Code of Practice. And if anybody breaches the Code of Practice, then we can take action to discipline the licensee. We provide details in the Code of Practice. If anyone who breaches the code, he or she will be punished under the disciplinary arrangement. Is the code just limited to doctors, or can the code be applied to the dispensaries? And if they don't comply, will there be consequences? The AD. It depends on the nature of the code. If it is the code under the Pharmacy and Poisons Ordinance, then the code is for the retail dispensaries and also the wholesalers of medicines. The code for doctors promulgated by the Medical Council. We only regulate the medicine trade. Concerning separation of prescription from dispensing, I think that should be implemented earlier in order to protect the consumers. Ms. Albert Chen, I'm not well versed with this issue, but I want to clarify the liabilities and duties. The operation of our dispensaries in Hong Kong is very different from the registered pharmacies. Now, say in some overseas countries, when they have a big pharmacy, they separate the part that is looked after by the pharmacist, and the medicine that is looked after by the pharmacist are separated from other products sold within that pharmacy. I am not able to understand the relationship of the pharmacist and the dispensary in the future. Would the pharmacist be independent? If you go to a dispensary, you ask if there is an effective medicine, then the elderly gentleman would get a few number of pills from the bottom of a drawer, and he told you that they are effective medicines. That I know is against the law, but that is a practice that is present in many dispensaries, local community dispensaries. And there is also that is the problem of dispensing medicine without the supervision of pharmacists, and also dispensing of faked medicine. If the pharmacist is the boss, then he may take the responsibility as a boss rather than pharmacist. But if the pharmacist is not a boss or not one of the directors, the shareholders, then what is the duty of or responsibility of the pharmacist? As for the second question, I will ask the AD to answer it. As for your first question concerning the dispensary, which requires the presence of a pharmacist, let me clarify this. Under the law, for 2/3 of the time of the business hours, a pharmacist has to be present. Without the presence of a pharmacist, then medicines that are regulated cannot be sold. And that is the present situation. A quick follow-up, I don't know. Say, especially strong medicine, which was obtained from the bottom of the drawer and then sold to me. There is no regulation. So is it the responsibility of the pharmacist or the gentleman at the counter, the AD? This is a law. It all depends on evidence. When one goes into a dispensary, if somebody gets some pills from the bottom of a drawer and sells the medicine to another person, and if that medicine has to be based on a medical description by a doctor, and if there is no description, then selling it is against the law. If you are the boss of the dispensary or a person described in the law, then it's in breach of the law. So either the boss or the company that holds that dispensary is in breach of the law. What about my first question? The scope of regulation. Is there any difference if the pharmacist is the boss or not? That yes. I try to be simple in giving the answer. The idea is this. We regulate the medicines. There are certain regulated medicines. They have to be managed by professionals in terms of its sale and use. In overseas countries, they have a pharmacist locking up all these medicines. I understand that. Say the pharmacist is responsible for this part, but within the dispensary there are people selling other regulated medicines. Is the pharmacist responsible for that? Said by, it really depends on the situation. Said by Ms. Wu, if the dispensary allows it, then the pharmacy is in breach of the law. If the person does it on his own, then the person is in breach of the law. Some medicines may not be poisons. They call it special effective medicines. That may be regulated or may not. It depends on the situation. What about the premises? The license is issued to the dispensary, and the DH looks at the dispensary, see if it is a suitable premises. And there are licensing conditions. Say dispensary sells tissue rolls. What has it to do with selling medicine? It's the same. It's in relation to a particular address. Mr. Chen, she already explained. The license is given to a premises at a special address, and it covers the locked up area and the area that has no locks. It's very likely that the pharmacist may be held criminally liable simply because of the activities in other parts of premises. The pharmacist is only one of the persons working at the premises, and he is held responsible. But the pharmacist shouldn't be held responsible for all the activities within the dispensary. That's not the intention of the law. Well, the law is implemented according to it, is according to what is written. There is no distinction within the premises. It's the same address. Ms. Priscilla Leung, I want to know more about the situation. Now we go to dispensary to buy medicines very often. The boss of the dispensary is a businessman. The professional code has higher requirements on the pharmacist, and if there is any breach on the part of the pharmacist, then there may be disciplinary action, and there may even be criminal liability if it's about life and limb. and people rely on professional judgment. You allow people to do business in certain professions, and that may and there are loopholes, and we are able to see some loopholes in the dispensary business. As for drug safety, the dispensary is required to have the presence of pharmacists for 2/3 of the business hours, and the key is held by the pharmacist. And if the boss has made a copy of the key, he has access to medicine and other people, and he is able to sell these medicines to the buyers or to the customers. I think the person who made the mistake should be held responsible. Do you have special requirement that the pharmacist will have the key only and the boss shouldn't have the key? And that's a very important arrangement. We've heard complaints, and we've also heard requests for help because the boss has the key. Can you address this question? The Undersecretary, Ms. Leung is right. Under the existing law, the pharmacist is the person who has the key only. Now, for the 1/3 of the time when there is no pharmacist present at the premises, then the medicines that are in the locked up receptacles cannot be sold. The boss cannot copy a key. But we've heard that within the trade, some have sought help from us. They said that the pharmacists were really frustrated. The boss has a copy of the key, and when there's a problem, the pharmacist is held responsible. In the past, there were court cases. At the end, the person who was not a pharmacist admitted or pleaded guilty. Otherwise, the pharmacist would have to pay a lot in fighting the battle, legal battle. Now, 1/3 of the time doesn't have the pharmacist. How can you make sure that there is proper supervision? The AD, the pharmacist has to keep the key. When the pharmacist is present, he has the duty. He holds the key, and then he can sell the medicine. He can check whether the medicine is suitable for the patient. He has the professional knowledge. When he is off duty for the other 1/3 or remaining 1/3 of the business hours, the boss has no power to come into contact with the controlled medicines. If it is found that when the pharmacist is away, the medicines, controlled medicines, are still sold, then we'll conduct an investigation to find out who is responsible. And then in the investigation, we try to find out who should be held responsible. It may be the case that the key is given to a colleague or somebody has taken the key. Now, for 2/3 of the time, there will be a pharmacist. But will there be a situation in which the medicines are sold without the presence of pharmacist?
Undersecretary, I think this is a licensing condition. If someone runs a dispensary, he must comply with this licensing condition. Does it apply to all? Because some may be so-called a drugstore, they only sell drugs. Assistant Director, that depends on what kind of drugs or medicines the dispensary is selling. If Part 1 poison is sold, a registered pharmacist should be present at least 2/3 of the times during the business hours of the dispensary before the license will be issued. And you may be talking about the LSPs. They don't have the license to sell Part 1 poisons, but they can sell other kinds of medicines. So I think on education, something should be done because the public may not be able to differentiate the two. And also the 2/3 of the business hours, I hope more publicity can be done. Sorry, your time is up. We don't have time. We're 5 minutes behind. Mr. Vincent Fang. Second round. I was really fortunate that I have a second round. I hope the administration can make it very clear. Let's say 2/3 of the business hours. What does it mean? 12 hours, 20 hours? Are you referring to the hours during which Part 1 poison will be sold? If I don't sell that kind of drugs round the clock, I can actually open the dispensary 24 hours. I don't think this is the case. I asked the Assistant Director to clarify. This is the provision. It states that for a license to be issued to a dispensary, a registered pharmacist should be present on the premises 2/3 of the business hours. So I think the administration should look at the reality. I'm not talking about chain stores. Smaller dispensaries, first of all, they run at least 12 hours a day. Some may even operate until midnight. And very often they don't sell medicines, they sell formula milk or even water. And if you require those dispensaries to close for the day, this might have a serious impact on SMEs. A point of clarification. We require the registered pharmacist to be present on the premises for 2/3 of business hours. This is the existing law. This is the existing licensing condition, and our legislative proposal doesn't touch upon this requirement. Yes, but I think the administration should be more realistic. Let's say the dispensary opens for business at 9 o'clock in the morning. If you say 2/3 of the business hour, that means it can run for 8 hours only when the registered pharmacist should be present, and it can then operate 4 hours without the presence of a registered pharmacist. That means it cannot operate for more than 12 hours a day, assuming that the pharmacist will be present for 8 hours. I think that's the case for ASP or dispensaries. For LSPs, other smaller dispensaries that don't focus on selling medicines and sell other products, they will not be subject to this control. So it will be all right if I don't have anything to do with Part 1 poison. Mr. Fang's right. If there is no Part 1 poison involved, no pharmacist will be required to be present, and no license will be required. No, I'm talking about pharmacists for the dispensary who will be there for 8 hours, and the dispensary sells both, not only drugs but also other goods. So I should be abiding by the law around the clock. So you should make it clear in your paper that by 2/3 of the business hours refer to the hours during which Part 1 poison is sold. Otherwise, all dispensaries in Hong Kong are currently breaching the law, because unlike what happens in the United States, we don't divide the store into a dispensary room and a counter front. At present, the whole shop front will be regarded as a dispensary, and If so, if I just sell water, then I can't even be allowed. That, Mr. Fang, I think there is a problem with your argument. You use the business hours as the nominator, and you divide you multiply by 2/3, etc. No, I mean, if I run a dispensary and I want to sell peppermint poison as well as water, then when the pharmacist is not here, can I sell water? You can sell water during 1/3 of the business hours. You cannot ask the administration to relax the existing legislation. No, I'm not asking for that, but I think the administration is not facing reality. That's not the reality. The reality is, so you're asking for the current legislation to be relaxed. So the administration would note your point. They understand it. So you just turn a blind eye towards this. You know this is happening. I'm sorry, time is up. We're running 15 minutes late, and we are going to discuss the next item at length as well. So the panel supports the final legislative proposal, right? So next item, surgical outcomes and monitoring and improvement program of the hospital authorities. We need to invite some other representatives from the administration in first. Dr. Kwokaki and Mr. James Toh together wrote 3 letters on surgical outcomes and 2 individual cases and the policies behind these 2 cases. And our item covers all 3 issues. And the background brief and the administration's paper have been circulated to members. And 2 deputations or individuals will be giving their views as well. And the Association of Nurses have also provided written submission. So that's from the Association of Hong Kong Nursing Staff. And 2 deputation or individual will be giving their views. One being Dr. Wong Chow Ming and the other being Tuen Mun Hospital Doctors Association. So may I remind the 2 of you, in short, you're not protected under the Electoral Powers and Privileges Ordinance. You're responsible for the remarks you made here, and each will be limited to 3 minutes for the time being, so please be succinct. Members may have questions later on, and you can supplement by then. So may I first invite Dr. Wong Chow Ming. Thank you, Chairman. I'm Dr. Wong Chow Ming. Between 1990 and 2006, I worked in the Department of Surgery in Tuen Mun Hospital, and before I left this post, I worked as consultant. And in relation to the assessment of Tuen Mun Hospital's performance, Tuen Mun Hospital ranked the bottom for 5 consecutive years as far as surgery is concerned, and I have some comments on this. Let me analyze the issue from various perspectives on the background of patients and the particular circumstances of anti-West cluster. And Tuen Mun Hospital should belong to anti-West cluster instead of standalone Tuen Mun Hospital. There are 4 hospitals in new anti-West, 2 being psychiatric hospitals, and the other 2 are Pok Oi and Tuen Mun hospitals. And for Pok Oi Hospital, in terms of facilities, manpower, and other supporting facilities, you can't call this an acute surgical hospital. So, in short, Tuen Mun Hospital takes up all the emergency surgery cases in the whole of anti-West. Thirdly, in terms of the culture of HA governance, let me say something about it. On the patient's background, I think we all agree that in anti-West, the majority belong to the grassroots level. We also have rural villages, elderly people, and ethnic minority groups. And in terms of the health knowledge, it's not sufficient. They are less well off, and there is less social support for them. So the situation is not quite desirable. So when they suffer from an illness, they only come to seek medical attention at a very late stage. And when surgery is needed, we discover that in fact they have already been suffering from some chronic illnesses known to them. And this also affects post-operative care or the development of complications. And because of the distinct geographical features of anti-West, all residents in the area requiring emergency surgical care are deterred from seeking medical help in other areas because of the long journeys involved. So even if they have the means, or even if they wish to go to other districts, they in the end would go to Tuen Mun Hospital. Should he be may I be allowed 2 more minutes? We must follow the rules. I will allocate 2 minutes of your time to him later. Next, Miss Dr. Wong Chun Sing. Good afternoon. I'm Dr. Wong Chun Sing. I represent Tuen Mun Hospital Doctors Association Surgical Unit. Now, in relation to the fifth report on the Surgical Outcomes Monitoring Improvement Program, I have the following views. Tuen Mun Hospital has again been rated unsatisfactory as far as surgical is concerned, and I am disappointed in terms of clinical performance and operation of the hospital and the shortcomings of the hospital's administration. Over the years, we have implemented improvement programs, and this is also acknowledged by and the problems have to do with insufficient resources. Anti-West has the highest population. We served close to 1.1 million patients, and as mentioned by Dr. Wong just now, because of the geographical constraints, few patients go to other clusters. And between 2012 and 2013, the number of inpatients for Department of Surgery was 13,000, and the bed occupancy rate reached 106%, which was very high, and that data was actually collected during night time. Imagine what happened in the daytime. And during daytime, for a 13-patient ward, at the same time, it might take in as many as 15 patients. It's so crowded, and it exerts very heavy pressure on our workload, and we have been suffering from long-term manpower shortage together with heavy workload and a negative image. Many new doctors are unwilling to work in Tuen Mun Hospital, and the heavier workload also turn veteran or experienced doctors away.
We have vacancies more than 10% of our strength. We are operating at 90%, less than 90% of our manpower to deal with 100% of work. We have to work long hours. It is not the standard working hours. We have to work till late at night. we cannot count all our overtime because of extended operations. We are very busy and we have little time to rest. I think you've already spoken quite a large portion of your view, and later there may be time for you to make a supplement. Well, shall I allow the administration to say a few words first? Yes, the Secretary, would you please respond if necessary? Thank you, Chairman. I'd like to thank the two Dr. Wongs for sharing with us their experience in sharing and feelings. And I thank members for inviting us so that we and the representatives of the HA can speak on the SOMIP and or surgical outcomes monitoring and improvement program. We are to provide quality service and safe service. A number of measures have been implemented by the HA to monitor clinical outcome. Since the 1990s, the HA has introduced the clinical management team framework to strengthen the clinical service. In 2008, the HA introduced the SOMIP to monitor the surgical outcome of public hospitals and identify areas for improvement. In fact, Dr. Wong mentioned that. The HA visits various hospitals, explain the reports, and listen to the concerns of the staff members and make specific recommendations for improvement. I stress once again that the improvement is very necessary. This will improve the surgical outcomes of the hospitals. We will continue to work with the medical staff to enhance our medical service. To enhance transparency, the HA announced the outcome. When the HA announced the outcome of this program, open forum is organized to enable all staff to discuss the reports. The report media briefing is also provided to the media and answer questions and clarify any misunderstanding. The HA has adopted a highly transparent approach to implement the SOMIP. It shows that HA attaches importance to quality of service. As pointed out by Dr. Kwok earlier, after the report has been issued, the majority of the attention is given to room for improvement, but the positive side of the report has not been mentioned. The frontline medical staff, therefore, have faced quite a lot of pressure. That's not what we want to see. That goes against the objective of the program. In fact, the program is forward-looking. Through comparison and analysis and sharing of experience, quality of service can be enhanced. According to the 2012-13 report, the success rate of surgical outcomes of the HA in comparison with the records of the past 4 years, or in comparison with other advanced countries, the outcome, the standard is satisfactory, and there is also improvement in the death rate. As for scheduled operation, it was only 0.7%. It is no worse than other advanced countries. As to the details of the program, I'll invite Dr. Au of the HA to speak on the details. There is not much time, Chairman. Is it possible for us to ask questions? They have ample time to answer. I think the main crux of the presentation is in the paper. And I believe members will ask questions, and they may ask for more than one round. Shall we extend the meeting? I don't mind. Please, brief and precise. 4 minutes each. James To, K.K. Kwok, Alice Mac, Priscilla Leung, and Chang. Chairman, Mr. James To, Chairman. Paragraph 18. A victim in the Manila incident. Now she has disclosed that publicly. It is about Ms. Yik. The issue is this. Some emails had been disclosed. Apparently, a certain surgery or a certain operation has been delayed because of non-medical consideration. On the 17th of January, it is said that in the 17th of January there was a meeting with Dr. Hong, the cluster chief executive. But up till now, there has been no decision of whether to make the emails public. If there is no public disclosure of the emails, then the scenario was that Dr. Chow looked at the case and then he said something and then nothing can be changed. Now you cannot just say that it's said out of context, but only you have access to the email or emails. Ms. Yik is not asking for just disclosing the details to the public. She wants to know the details because she is the patient. She has to be informed why there is no operation. She has the right to know the discussions about her operation. As for para 19, I am helping Professor Yu to seek justice. The Medical Council has got 6 experts, overseas experts, and every expert said it was okay. But the Medical Council had a later starting point than the HA. The HA spent more than 1 year on the issue. Public interest there is public interest. It's not just about Dr. Yu's reputation. He is a very senior doctor. He can do a lot of complicated surgeries. And if you suspend him from doing the surgeries, then a lot of patients will continue to suffer. And he provides a lot of training. He works in public hospitals. He trains doctors. He doesn't go into private practice. And he is suspended from doing any operation for a year. That really undermines the rights of patients who are suffering from very complicated ailments. The Medical Council has already issued its report. Why it takes so long for the HA to compile its own report? The Undersecretary. Thank you, Chairman, and thank you, Mr. To, for this question. Your question about Ms. Yik. The hospital authority has already said earlier that all was based on the clinical decision. As for making the emails public, maybe Dr. Hong can speak on this. Dr. Hong. Chairman. Last time we met with Yik Xiuling, we explained to her that the decision to do the operation or not and when to do the operation was a clinical decision. Ms. Yik wanted to see the emails. The HA and the cluster actively consider what emails she could have access to and what she could not. We are considering a number of factors. We know Ms. Yik's wish. The second question can only be followed up after if we have some more time later. Dr. Kwok, I thank the 2 Dr. Wongs from the Tuen Mun Hospital. The problem of Tuen Mun Hospital doesn't arise today. It was opened in the 1990s. Last time, when the Health Services Panel discussed the matter, it was 2004, 10 years ago. If you are really forward-looking, why after 10 years Tuen Mun Hospital is still most neglected. NT West cluster still has the least resources. It is very different from other districts. In Kowloon, in Hong Kong Island, the patients can go to private sector doctors. They can also go to other clusters. But for those in Tuen Mun, they cannot go to other clusters. If the HA has read the report 5 years ago, it has done something, then why after 5 years the matter is still the same? What lesson has been learned by the hospital authority? What improvement has been made to the Tuen Mun Hospital? Now there is a proposal to turn Pok Oi Hospital into a hospital that can perform emergency surgery. Now some doctors told me that would only cause more deaths. Now, Pok Oi doesn't have an adequate ICU. It doesn't have adequate facilities. Just shifting the patients there cannot solve the problem. Can it? Are there long-term ways to deal with that? Say in other clusters which have more resources, can the resources be transferred so the NT West can have more resources? The problems pointed out 5 years ago, have they been solved? Why the problem is still there? The Undersecretary. Thank you, Mr. Kwok. At the kick-off speech, I've already said that the program is to make improvements apart from doing analysis and comparisons. Now, the two Mr. Wongs mentioned that the Tuen Mun have very special situations. If you look at Tuen Mun in the past 5 years, there has been improvement. And I can ask Dr. Au to speak on the improvements. Chairman, I want to give more time to Dr. Wong to speak on the Pok Oi issue. Dr. Wong. Mr. Wong Chak-ming, you can speak on those which you have not completed. You only have 1 minute or so. Tuen Mun should be considered from the NT West perspective. When Pok Oi was opened, it was designed for non-emergency surgery. As for ICU and other and also it is for patients who do not require much ICU service or much support. Pok Oi is not for severe illnesses. Pok Oi is only for not so severe illnesses. If you move acute patients, serious ill patients to Pok Oi, then it may not be able to cope. And then Tuen Mun, the doctors for Tuen Mun are also the doctors for Pok Oi. If you just transfer the doctors from Tuen Mun to Pok Oi, then there is only the thinning out of resources. Chairman, are they going to implement their plan? If they are going to implement their plan, there would be more deaths. Will the HA be responsible? They still have time in the next round. Okay, next, Ms. Alice Mack. The scheme is to find out opportunities for improvement, but we can only see monitoring, and we have not seen any improvement. Some have already said that Tuen Mun is very special. In Tuen Mun, the ratio between patients and private practitioners are very different from other districts. There are more private practitioners in other districts. There are less in NT West. In Tin Shui Wai, in Tuen Mun, there are many poor people. In some housing estates, you can't get a private practitioner. Let's don't talk about private wards or private hospitals. There is a strong demand for public sector hospital service and public sector medical service. In this council, we have discussed a lot on the distribution resources in NT West. NT West is given less resources. Now they say there is increase in resources for NT West, but if you compare NT West with other clusters, you will see that the ratio given to patients is poorer in comparison with other clusters.
So, first of all, I'm wondering, even with this report, what about improvements? Over the years, it has been said that there is room for improvement, but what actually has been done? You should not be complacent by just telling yourself that you have been performing better comparing to last year. This is not an acceptable explanation. So, question for the administration or the HA in terms of manpower. As the healthcare sector points out, manpower is the biggest problem facing NT West. I agree that overall speaking, we have a manpower shortage, but this problem is particularly serious for NT West. So what will be done? Under Secretary. Now for Tuen Mun Hospital or NT West cluster as a whole, we note the issues raised. And over the years, Ms. Mack mentioned resources, and perhaps I can give you some figures. For example, from 2008-09 to 2012-13, on an annual basis, the increase in resources for NT West was more substantial than other clusters, 8% more. So resources have increased, and of course there is room for improvement. Just now Ms. Mack mentioned improvement, and I'll defer to Dr. Au to say something about improvements. He didn't have the chance just now. Thank you, Chairman. Well, if we have time, actually our Tuen Mun colleagues have prepared information on the improvement program. Every year, through implementing specific programs, we allocate more resources to NT West as well as Kowloon East on improving surgical outcomes. Well, pork oil is part of our program, but it is not all. When we roll out the program, we have a centralized surgical professional team, including Dr. Mok, etc., who will devise an annual improvement program on a rolling on basis, and I agree that we should further improve it. Next, Dr. Priscilla Leung. On public hospitals, public health care, I think I'm in all support in terms of increasing resources for whichever cluster, and in particular on resources to improve manpower. Even for Kowloon West, recently I have received a case, and the patient has been very tolerant. I have been following up on the patient's case for a year and a half, and the patient was supposed to do bypass surgery, and he paid several $10,000, and he told me that the surgery was performed by a trainee doctor supervised by a senior doctor, and after the operation his legs got swollen, and then he was asked to do a further examination on his stomach, and then the incision was done wrong, and another examination or surgery was necessary. And I agreed to write to the HA to follow up on it, and the patient's health seriously deteriorated, and the patient didn't want me to lodge a complaint, as that would mean somebody being fired. So the patient was being very tolerant. I live in NT West. I understand that there is a severe manpower shortage, so definitely it will affect the surgeries. Doctors need to rest. They're already working overtime all the time, and they also need to report to duty in the middle of the night. And I think all my colleagues would agree that you should improve manpower. And not all patients are willing to blow this up by, say, having a press conference. Is there any internal mechanism so that compensation can be offered by discretion after the operation, rather than resorting to political means? Because we have to face a reality that because of severe manpower shortage, things may get substandard, and sometimes the complaints may not be able to be substantiated after lengthy investigation. So internally, do you have a mechanism to make compensation to patients so that we don't need to resort to political means? Under Secretary. All right, maybe later I'll defer to Dr. Au to say something about improvement, because I have the impression that members would like to know what work we've done and how we're going to resolve existing problems. But you should respond to Dr. Priscilla Leung's question first. Her question is whether you have a mechanism to make compensation by discretion. Dr. Au, we can follow up on individual cases. We're taking a multi-pronged approach. We also have a public complaints unit, and some cases have indeed been settled by mediation. So not all cases are resolved through legal or political means, and I'm happy to follow up on individual cases. Yes, please do, because not all patients would go to counselor, because it will become very political. So please consider setting up a more effective and efficient system. Next, Dr. Ann Chang. I'm sorry, Chairman, I have another meeting next door convening at the same time. I don't know whether this question has been asked by other members. The Association of Tuen Mun Doctors, Dr. Wong, raised some issues, but it seems that not all issues are covered. So I'd like to invite him to say more on this and what solutions they suggest, or he suggests. I think it's difficult to answer to all these issues. These are just my observations. For example, more resources can definitely help us perform better. And to cite an example, we have heavy workload, we have tight manpower, we have less than 90% manpower in our establishment for our work, and apart from elective surgical cases, for emergency surgical cases, our frontline doctors have no time to rest, and after overnight shift, normally frontline staff would get a half-day rest, but because of the heavy workload, these frontline colleagues would voluntarily stay behind to help with easing the workload, and overall speaking, this is not desirable. So, Under Secretary, what should be done? Should more resources be allocated and manpower be increased? Under Secretary. Thank you, Dr. Chang. I think previously at the panel, the HA colleagues repeatedly make this point. They have implemented some measures on recruiting manpower. Manpower is, of course, a major issue, and the administration has a steering committee on manpower planning to cope with future manpower needs. But at the same time, we need a quick fix for our problems in the short term. And we have various measures, in particular some for anti-West. Maybe I will defer to Dr. Tony Cole, to say more on this. Now, Undersecretary, my time is almost up, so please tell me whether you will implement a dual-track system or a two-pronged approach. Say, for the short term, will you recruit more overseas doctors, eligible doctors, and more desirably, they should also be permanent Hong Kong residents. This can be done immediately. Secondly, in terms of quotas for medical students, you should further relax it so that we have more doctors in Hong Kong. We have been discussing this issue for so long. You should disregard the views of the medical council or association or whatever. They will be protecting their own interests. But our population is growing, and there will be visitors amounting to 70 million. So we really suffer. Look at what's happening in Tuen Mun Hospital. More doctors will join the private market instead. So, Undersecretary, please reflect this view to Dr. Ko Wing Man for further consideration. Mr. Poon Siu Ping. Thank you, Chairman. I thank the two doctors for telling us the situation in Tuen Mun Hospital. Insufficient resources is all along known to us. What we want to know is how we can improve the situation. According to the information, every year, about 3,800 patients would be transferred from Pok Oi Hospital to Tuen Mun Hospital. And in other words, the bed occupancy rate for Tuen Mun Hospital stood at 106%. And according to the information, one of the recommendations is to optimize the utilization of Pok Oi Hospital by providing emergency services in Pok Oi Hospital. Right now, Pok Oi Hospital only handles elective surgical cases. So will there be any new measures? And in Para 15, HA has actively explored means for improvement in respect of COC surgeries observations. QEH, Tuen Mun Hospital, and PWH will set up surgical high dependency units in 2014-15. I'd like to know more about this. How many will be added, and what about manpower? Undersecretary. Thank you, Mr. Poon. I think I'd better defer to Dr. Tony Cole, because we have really done a lot. Dr. Cole. Thank you, Chairman. As mentioned by the Honourable Member in Tuen Mun Hospital and Pok Oi Hospital, in terms of delivery of service, Tuen Mun and Pok Oi Hospital are both acute hospitals. However, Pok Oi Hospital has yet been able to provide the full scope of service. So far, Pok Oi only handles elective surgical cases, whereas all emergency cases are dealt with in Tuen Mun hospitals. So every year, some 30,000 cases are transferred from Pok Oi to Tuen Mun Hospital for emergency surgeries. And in the report this year, one of the observations is that for high bed occupancy rate, for example, Tuen Mun Hospital very often exceeding 100%, this would not be desirable. And for Pok Oi Hospital, the bed occupancy rate is relatively lower. So rather than transferring the 3,000 patients from Pok Oi to Tuen Mun, we should consider whether the capability of Pok Oi can be enhanced to take up more emergency cases. And Yuen Long residents can also receive surgical care within the same district. And in fact, Pok Oi Hospital has medical ward, ICU, and also computer scan facilities and surgical wards. surgical doctors, anesthesists, and nursing staff, we're experiencing shortage. That's why we cannot take up all the cases in which patients require emergency surgical care. And in the coming year, we will gradually improve the capability by providing more beds and more consultation sessions. And the other difficulty facing Tuen Mun Hospital is that apart from manpower shortage, they do not have sufficient operating theatres. And whereas for Pok Oi Hospital, there is room to enhance the service in this regard. So we hope by enhancing such service, we can alleviate the high bed occupancy rate in Tuen Mun Hospital.
And there is a need to enhance the manpower and resources of Tuen Mun Hospital. With regard to provision of emergency surgery service, is a very important issue, and we have to deal with it very carefully. The surgeons and the anesthesists have to work together. When there is an emergency operation, we need nurses, we need anesthesists, and also surgeons. They need to work in teams, and they need to work together. We try to make suitable arrangements so as to gradually reducing patients from transferring patients from Pok Oi Hospital to the Tuen Mun Hospital. Next, Mr. Chen Kim Po. Thank you. Paragraph 12 of the paper mentions that in the SOMIP there is room for improvement for Prince of Wales Hospital. But in fact, PWH is a teaching hospital. It is a teaching hospital for CU's medical school. Why they still need to make improvement in terms of surgical outcome? One of the explanations may be the relationship between after surgery, the use of ICU after surgery. Will the performance of PWH in terms of surgical outcome undermine medical teaching? The second question is in relation to Tuen Mun Hospital and Pok Oi Hospital. Dr. Wong said that they are the same group of doctors. They are using the same group of doctors. So just transfer patients between the two hospitals is not adequate. Now, there may be a lot of private practitioners who are willing to help. So will you consider making use of private sector resources? Can you have more flexible and attractive arrangements to attract private practitioners to help out? Concerning PWH, Dr. Mok can speak on the situation. Dr. Mok, please. Chairman, concerning the performance of the PWH, it was good in the past. This is the first time over the years to have not performed well in respect of emergency surgical service. Our analysis is that with the development of PWH, its ICU cannot cope with the increasing demand. Our solution is to add more dependency beds. Patients under elective surgery do not need to stay in the ICU, and yet they can still receive post-surgical attention, adequate post-surgical attention. The ICU can therefore be used to cater for other patients who have the need. We think this is only a temporary issue, and it will not undermine the teaching quality of the medical school. Well, we have to trust you. You have found the reason, and you have made recommendations, and I hope that is a correct one. What about my second question? The second question is about Pok Oi and Tuen Mun. Mr. Chen asked whether private practitioners can be invited to help out. In fact, the HA has done a lot of work in recruiting part-time doctors. Probably Dr. Ao can supplement. Dr. Ao, please. With regard to recruiting private practitioners to help out, well, my previous posting was human resources. 3 years ago, there were 100 private practitioners doing part-time for the HA. When I switched to this post, there were 310 private practitioners taking up our part-time post. It's no small number. Tuen Mun Hospital has a larger number of private practitioners doing part-time. As for surgery, the workload cannot be shared out by private practitioners. As said by Dr. Mok earlier, the performance of different hospitals varies, and the contributing reasons are also different. As for PWH, it is about the use of ICU, whereas for Tuen Mun is about after surgery care. If we can have a less crowded ward, there can be better care, and that can help to reduce the problem. And next year, there may be other opportunities for improvement. We cannot identify all the problems at one go, or we cannot solve all the problems at one go. Ms. Kwok, I want to speak on PWH. PWH is not just serving Sha Tin, it's serving the whole NT East. The situation in PWH is very bad. During the Lunar New Year holidays, you can read from the newspapers that the waiting time was very long. PWH has also underperformed in terms of emergency surgeries. I think there are 3 problems. First, there is the lack of long-term planning for different clusters. There has been lack of research. The second problem is hardware. There aren't enough hospital beds. The third is there aren't enough doctors and nurses. We have discussed it on many occasions. And the HA has just been repeating its answers. Yet the answers are not satisfactory. As for PWH, there is land available for a second phase expansion, but the expansion scheme has not been launched. I hope you can explain to us that you are doing the demand for healthcare service NT East, why it takes so long to do the study, and when will there be a second phase expansion. Now the temporary beds or camp beds in the corridors may become permanent beds if you don't have an expansion. We want more doctors. You've given us some answers, but we still don't have enough doctors to solve the problem. We're talking about lives, saving people's lives. If there is a way to increase the number of doctors, increase the number of hospital beds, we have to do our best. We have to do that. And thank you, Mr. Kwok. Concerning your questions, you write in pointing out that we have discussed it with this council on many occasions. As for long-term plan, the HA has been doing long-term plans. If you mention hardware, I think earlier on the Policy Secretary has mentioned a blueprint. There is a blueprint for redevelopment, and new development for various hospitals in the territory. As for manpower, we've also mentioned that the HA has adopted various channels and means to increase manpower in the short term. And 1 or 2 years ago, we have increased the number of medical students, 50 for each medical school, altogether 100. But it takes time to train up the doctors. At present, we have some short-term measures to enhance the manpower of doctors. As said by Dr. Ao, before he is posted to the present post, about 300 part-time doctors have been recruited. As for NT-East, perhaps Dr. Ao can say a little bit more. Yes, Dr. Ao, please. Concerning the number of beds and manpower, shortage of manpower, each cluster is suffering from a shortage. NT-East and NT-West face rising demand, or the highest rising demand. That may be because of the population structure. Dr. Ko Wing-man has reviewed the situation with the HA in respect of forecasts of hospital beds. NT-East is given priority in finding sites, say a site near Taipo Hospital, site near North District Hospital, and also a site in Peter Beach. How soon would that be? How soon would that be? Peter Beach Phase 2. How soon would that be? It has been, the feasibility study has been advanced. The feasibility will start this year. When will the proposal be given to us for approval for construction? I have to go back to my colleagues and check my colleagues on planning. I will ask the first round, and four members want to have a second round. I'll extend the meeting for 15 minutes first for the time being. My question is this. Concerning surgical outcome. Now you've analyzed the reasons contributing to the variation in surgical outcomes. It really depends on what factors you consider. Some may consider crowdedness in the ward, manpower situation in the hospital. If you put that factor in, then the factor can be reviewed or can be revealed in your analysis. Now, if you look at NT-East, NT-West, and other clusters, if you look at the funding, NT-East, NT-West have less in 2012 and 13. If it is per 1,000 population, NT-East, NT-West 4.7 million odd, NT-East 4.9 million, Hong Kong about 8 million, and Kowloon a million, more than a million. Say for surgery, the funding for the clusters divided by population, can that be included as a factor? And have you done that? You mentioned crowdedness in the ward. If you don't have the doctors and nurses, even if you have 100 beds more, you can't do you can't solve the problem if you only have Dr. Wong and nobody else. Beds and manpower are related to funding. Have you considered funding per population as a factor in your evaluation? Dr. Ao. Let me answer that briefly. Concerning funding per capita, we don't just look at the static situation. We have to consider the dynamic situation. I take your point. You don't need to continue. I ask you not to continue. Okay. You say that in some clusters they have more resources because they care for the patients of the clusters, and therefore you cannot just look at the static population per capita. Therefore, I have come up with another set of numbers. I look at your factor. Let us look at SOPD patients. The numerator, those patients coming from NTEs as the numerator, and the total population of NTEs as the denominator. And then I come up with a usage rate. I've found it for 7 clusters. The usage rate has been adjusted to deal with the cross-cluster consultations. What is the conclusion?
And that explains the poor situation in Kowloon Central. For NT East, the utilization rate was 64, followed by NT West 67%, and Kowloon Central 68%. So those getting the highest medical resources should be Hong Kong West 79% and followed by Kowloon West 78%. That means for cross-cluster patients, they sort of even out part of the healthcare resources. But in the end, Kowloon West, Kowloon East, NT East, NT West, and Kowloon Central, the utilization rates are quite are apparently quite low. So how can you improve the situation? In the recent review conducted by the HA has prepared a whole set of figures in detail in relation to the resources allocated to each patient in each cluster, and the difference was less than 10%. So in some, that is the difference in terms of the patients using up resources in various districts was not high. Even after adjustment, it is true that for NT West, well, I will follow up on this later. I won't take up too much time. Second round first. Mr. James Toh, for Professor Yu Chapman's case, I invite them to respond to that. The Medical Council engaged 6 experts. Why has the HA taken so long? It should have been completed within reasonable time frame. It's a matter of public interest because Professor Yu also has to train other doctors, and he also has to perform surgeries for complicated cases. Under Secretary. Thank you, Mr. James Toh. And we have noted some issues raised by Mr. James Toh. We have engaged experts to prepare a report. The report have been completed. They have been submitted to our IRC, Independent Review Committee, under the headquarters of HA, and they are examining the report. And I'll defer to Dr. Au to supplement. To James Toh and to this panel, may I report the progress. The 2 expert panels submitted their reports respectively in September last year and January this year. The former panel being the audit report in relation to the PCI. As for the 11 cases, the detailed report has been submitted in January this year. And the headquarters, after receiving these reports, would go through all the details. There were many details in relation to gathering of evidence, and the reports contained over 500 or even 600 pages of medical information, let alone patients' information. And all the comprehensive data will be submitted to the experts for advice, and they are international experts, and they have been dispatched via speed post last week. And when we seek international expert advice, I understand the normal practice is that they take 2 or 3 months to complete the analysis before coming back to us. And because of the tight time frame, we have asked them to expedite their work and see whether we can be provided with a preliminary report in 6 to 8 weeks' time. We are talking about the complexity of these cases. We find it necessary to take a more thorough approach. As for the Medical Association's report, we have read the report very carefully, and we have also wrote back to ask for clarifications. For example, initially we clarified with them the source of information which have been forwarded to their experts, and according to their response, because we have a privacy concern, and their response was that those were information or details provided by Professor Yu and the medical team, and we further invite them to explain to us, as 6 experts were engaged to look at all the cases, and we would like to know whether all experts looked at all cases together, or whether some just read some of the cases. We need to ask these questions because we need to understand the basis of their report and the basis of their conclusions. For the IRC's consideration, because we have never come across a case in the past in which, when the IRC was conducting internal investigation, and an external party would at the same time submit an expert report, and that took us some time. Next, Dr. Wakaki, Chairman. Just now, I heard the response from the HA and the administration, and that wasn't an answer. These are long-standing problems in PWH and other hospitals, and Dr. Au, you also know about them. For PWH and TMH, yes, I agree that you're resorting to high dependency beds. And I have friends working in PWH, and after surgery, very often these patients are left to die because they don't have sufficient intensive care unit beds, and each hospital amounts to independent kingdoms, and they have the discretion to decide whether to take a patient or not. And this is the problem. You have independent kingdoms in each cluster, and this is a governance crisis. If you don't resolve the problem at root, this is just window dressing. This doesn't help resolving the turmoil inside, and we both know that. And secondly, with high turnover rate, this is a vicious circle. The work environment is poor, and a colleague just worked there. There was a 50-year-old patient suffering from diarrhea. The patient was hospitalized. Instead of giving the patient a container, he was given a diaper instead, and that was the way the patient was treated. And we shouldn't blame the staff because that was the resources they have. So it has a problem. It has to do with the allocation of resources. So for the poorest cluster, there should be a more even distribution. Thirdly, it is a structural problem, as we can see. Even if surgical unit is set up in Port Royal Hospital, this cannot solve the problem because you have the same team of doctors, only that you split them into 2 teams. So how can you have any result? And this cannot be resolved the other way around. For those not requiring ICU intensive care, they should be transferred to Port Hospital. For more serious cases and emergency cases, they should be treated at Tuen Mun, so that resources can be focused. Under Secretary, I can defer to my HA colleagues to answer your point on Tuen Mun Hospital and on allocation of resources. I must stress that over the years, the HA has been allocating more and more resources to anti-West, as I said just now. Under Secretary, I see this point. Everybody is eating 10 bowls of rice, but he's only eating 5. Even if you add 1, it's still 6 bowls. Comparing to other people, he's still eating less. On increase in resources, it is one of the highest among other clusters. So that patient is suffering from famine, and other people, while other people are eating rice, he is eating biscuits. Let me supplement. We don't wish to dodge the question. We take a multi-pronged approach. This is a crude figure. 8% for that cluster and 6 or 7% for other clusters. Over the years, things have sort of caught up, but this is not the solution. On sessions for applying anesthetics and operating theaters, and also high dependency beds, these are all important factors. I agree that looking back in the past 5 years, we haven't been able to address all these issues in one go because of development constraints. But anyhow, the anti-West, in terms of the resources, it has been accorded priority. And can this be resolved in just 1 or 2 years? No, but we are taking a step, and it may take another 1 or 2 years to resolve the manpower problem. 3 more members would like to ask questions for the second round. If there is no objection, I'll extend the meeting by another 15 minutes. Next, Ms. Alice Mack, Dr. Priscilla Leung, and Dr. Elizabeth Quat, and I'll draw a line there. Ms. Alice Mack, I'm not good at maths, but Chairman, does it mean that the base figure is so low, such that if you just increase a little, it may represent a substantial increase? So historically, anti-West has all along been given too little. Even if the increase is more substantial than other clusters, it doesn't mean that it will do a better job. This is not an absolute figure. We should consider the ratio between doctors to patients, and before we can see whether this district is getting sufficient resources. So even if you say you have allocated more resources, much more than other clusters, the fact is, in terms of the doctor-patient ratio, the situation is still serious. So you have stressed that more resources will be allocated. I hope this will be speeded up, and we're not happy just to see that the percentage of increase is higher for anti-West than other clusters. We should do more, and it's not just about shuffling the cards. If you don't increase manpower, you cannot do more. So maybe Dr. Ko also has limitations. I think you should allocate more resources among clusters more evenly. And lastly, there will be more operating theaters in Tuen Mun Hospital. We understand that in terms of figures, Tuen Mun Hospital is not doing is doing a poorer job than other hospitals, so more operating theaters are needed. And yet, what about manpower? And can it really help surgical cases in future under this program? Will this cause another source of pressure? Is difficult for us as well. We must ask for more capability because their figures are not good. But will this affect the services and the patients? And for staff in NT-West, we should give them more support because they have insufficient resources and yet they can do so much. So the point is about even distribution of resources.
I thank Ms. Mack for a question. Dr. Au can speak on this. Concerning adding operation theaters to Tuen Mun Hospital, whether there is enough manpower to cope, I think the HA has a whole package. Dr. Au. Thank you, Chairman. In the past 3 years, since the assumption of office by Dr. Leung Pak-yin, we've adopted an arrangement in which the head of each clusters sit together every month to discuss the detail. It's not just giving a lump sum for the whole year and then let each cluster does its own job. We have had detailed discussions. We therefore consider feasibility and then adding the item. We do not just give a big sum to a particular cluster and then let the cluster work it out on its own. As for NT-West, in responding to Dr. Kwok, I mentioned that the situation was very complicated. It's about a mode of operation. It's not just resources. We are looking at that. We're looking at the whole package. We look at many factors. As for specific improvement items, they are also our concern. Next, Ms. Priscilla Leung. I hope you will explain to us further on this. Will you consider allowing discretion to your most experienced doctors and then consider the case? I have done mediation, members follow up, lawyers follow up, and then the matter is settled. Nobody wants to admit the wrongs. Now, say if it has been assessed by a senior management of the senior management of the hospital, then discretion is given to settle the case. I think this will be helpful. I hope you will address this question. The second point is this. Now, every cluster is short of manpower. Every year, I ask for putting $10 billion into public sector, mainly in terms of manpower and also in provision of hardware. Now, because of aging population, this is very important. Now, if you take money from one cluster to another cluster, you are just transferring problems. You need to draw up a plan, and we can help you to solve the problem arising from shortage of manpower. 2 questions. Thank you, Ms. Leung. Let me answer your second question. The first one will be answered by Dr. Au. Concerning manpower, we know that there is rising demand for healthcare services because of population aging and other factors. So we have the shortage of manpower. Within the Bureau, there is a steering committee to review manpower situation. And the committee is looking at doctors, nurses, pharmacists, so on and so forth, altogether 6 professions. In terms of manpower, assessment, we've got the Hong Kong U to help us to do long-term planning. The CUHK is to help us with looking at professional development. What about compensation? Concerning compensation and whether discretion, more discretion can be given to the hospitals. Now it is about quality and safety. So my new posting looks at public complaints and patient complaints and the handling of complaints. I will listen to the members' view on coming up with strategy to deal with that. And I'm talking to the colleagues who are responsible for mediation. But I want to say this with regard to serious or sentinel events and also compensation, the number is declining. A lot of efforts have been made so that the complaints have declined and also the untoward events have declined. The mechanism is healthy. We have to go through the procedures very carefully. The patient may therefore feel that it is very difficult to express his or her grievances and get such grievances addressed. It's a matter of perspective. But we need to balance the use of public resources. I just want to add briefly. I hope you consider this. I don't believe that the hospitals abuse the use of money. They have to report to the hospital authority. You don't need to politicize the issue. You don't need to go to the court. It's more than just a word. Yes, we'll follow that up. Ms. Quat. Thank you, Chairman. I think we're just beating around the bush. We say there is not enough healthcare manpower. The administration says that we are training more doctors. After 2 years, there will be more doctors. And we are now recruiting doctors. We have already recruited that many. But the fact is there aren't enough doctors. After 2 more years, there will be more doctors, but you are still facing inadequate hardware. Now, if we don't have enough doctors today, from now until you get more medical graduates, what measures does the administration have in the interim in order to get overseas doctors and try and also liberate the market or remove the barriers? Do you have more effective measures apart from those you have done? Now, as for the expansion of phase 2 of PWH, you don't need to, there is already a site available. You have already got a site. How soon will you start the works? You only say soon, but is it about 3 years, 5 years, or how many years? If you can't tell me today, then it's not soon. You just try to dodge the question. It's about life. If you don't have adequate resources, if you don't have adequate hardware, then you really can't solve the problem of poor surgical outcomes. After a surgery, if you don't have an ICU bed, if you don't have a high dependency bed, then you really that will cost patients' life. That's why we are so keen, and yet you don't answer our question. You are able to answer the question today, try to do so. If you are not, then please come back to us as soon as possible. I need a timetable for PWH Phase 2. When will that be constructed? Thank you, Chairman. Thank you, Ms. Quat. Concerning the shortage of doctors, a few years ago, we increased the number of medical students, and we have to wait for the graduates. As for recruiting overseas doctors, we have been talking to the Medical Council. We've been working hard with the Medical Council to speed up the process. Now we have increased the number of licentiate examination from 1 examination to 2 in a year. Dr. Ao, Chairman, we don't have much time left. I've heard these answers many times before. Even if you add 1 more examination or 2 more examinations, we cannot see the shortage or the gap filled within a short period of time. It's not that we can't have more doctors from overseas. It's only because of protectionism in Hong Kong that good doctors from overseas cannot practice in Hong Kong in lieu of taking examinations. Now you say you still have to be protectionist. You're just willing to add more examinations. Is examination the only means? Is it really necessary? Can you be more open? You don't need to repeat your answer. I can say the same. People cannot accept that. Okay, can I answer the question? I thank Ms. Pratt for the question. In fact, we're not just talking, and we are in fact working on it. In terms of examination, the law authorizes the Medical Council to arrange medical examinations, to arrange these doctors' examinations, and they are to safeguard the health of the people. And after discussion, they still find that the examination necessary. Apart from examination, or with regard to examination, the enhancement of transparency. No, you say you've heard before. Now we've added 1 more examination. This speeds up the process and will enable more overseas practitioners to practice in Hong Kong. One has to be flexible. We need doctors to save lives. We don't understand why some doctors who have practiced for more than 20 years overseas and who have adequate experience and they still have to take examinations in Hong Kong. Are they not doctors overseas? Are they not saving lives overseas? People are waiting for doctors to save their lives. You need to convince people that only this can save people. Your explanation is not adequate. I think you've heard that. I think you're just repeating. I hope there can be a timetable for PWH expansion. The issue is resource allocation. The Health Services Panel has asked the administration to provide more details on the methodology of allocation resources and also the data. Dr. Ao says that the resources per patient varies between clusters for no more than 7%. But for me, for my calculation, the lowest is 64% and highest 79% in terms of SOPD. So the variation is more than 20% or nearly 20%. We've overrun by more than half an hour, but we have to call it a day. Thank you very much.